Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and once again I'm so happy that you joined us in this educational platform. And as you all know, over the past sessions and also past season, we try to cover almost all aspects in implant dentistry from the prosthetic point of view, from the surgical point of view, from the complications point of view, and try to overview and review all the concepts available and also the new innovations coming out, and with great practitioners from around the world, well-known lecturers that we can rely on what they present, and amazing presenters. And today, I have to say, a very, very dear friend, a superstar in the field of implant dentistry, and we call her Diva, a real diva in dentistry. Snjezana Pohl is here with me from Croatia. Hello, Snjezana, and welcome to Hot Seat, my friend.
Hello, Omid. Thank you for having me with you. I'm really and happy to join you alone for this intro video. I love it.
Thank you so much for joining, my friend. And I have to say, I'm pretty sure so many of dentists around the world knows you, so definitely you don't need any introduction. And I have to say, we are very thrilled that you joined us. And I think, again, so many dentists know that you are also a true expert in dental dentistry. And we are very happy to have you with us and following your amazing work, your researches, your beautiful surgeries. That I believe that for those of you interested, at least you should check Snjezana Pohl's page on Facebook and you will understand what I'm saying. So, today, very interesting topic going to be covered by her, which is the pedicle connective tissue grafts, the topic is, and the connection matters. So many innovations in the techniques was introduced by Dr. Snjezana Pohl, and today I'm pretty sure she will cover some of them for us. And definitely at the end of her presentation, we will have a great discussion on the topic. But before she starts, I would like to have her CV as a tradition of Hot Seat, and then we straightly go to her presentation, and at the end, we will have the discussion. Dr. Snjezana Pohl is both a doctor of human and dental medicine. She is a specialist in oral surgery and EDA certificated specialist for periodontology and implantology. She completed her graduate medical studies at the School of Medicine of the University of Zagreb, Croatia, and obtained her medical doctorate in 1987. She exhibits an experience of 2 years in general surgery and orthopedics in Munich. In 1997, she graduated from dentistry at Ludwig Maximilian University in Munich, Germany, and obtained her certification as a specialist in oral surgery in the same university in 2003. In 2002, she acquired her doctorate in dentistry at the University of Cologne, Germany, and in the same year, she received a specialist certificate for periodontology and implantology from the European Dental Association, EDA. She has been a co-owner of the Center for Oral and Maxillofacial Surgery in Starnberg, Germany for over 13 years, and currently she's joint owner at Ryden Clinic in Croatia and head of the Department of Oral Surgery, designated as an assistant professor, and additionally is giving lectures at the Department of Oral Medicine and Periodontology at the School of Dental Medicine of University of Rijeka. Since 2015, she's a lecturer at worldwide dental meetings and also became a dental XP expert. And as an active lecturer in the fields of implantology and periodontology, Germany, Spain, Italy, Croatia, and researcher of numerous publications in scientific magazines, she underlines the importance of minimal invasive techniques, especially in a comprehensive treatment methodology based upon preservation of tissues such as partial extraction therapies, which I have to say I'm so grateful to have Snjezana Pohl's chapter in Socket Shield book in Persian language for all the Farsi language people. also in autogenous tissue utilizations, osteodensifications, and other. Dr. Pohl modified the technique for simultaneous hard and soft tissue augmentation for socket type 2 in the aesthetic zone called MIVAN technique, which I hope that she covers a little bit in this presentation at least, and is an active member of the European Dental Association, American Academy of Perio, European Federation of Periodontology, and Croatian Society of Periodontology. With that said, now you all know that we are facing a true divine expert in the field. Snjezana, we are ready for your beautiful presentation, my friend.
Thank you. I didn't know that my CV is so long. I must be very, very old. Now, let me start my presentation. And you know, it's really easy to choose the topic because you really covered almost everything. Hovi has already gave presentation to the partial extraction therapy. So I thought we can focus on the pedicle connective tissue flap. And I think it is also a little bit because I know that you have done some research and taken part in using connective tissue grafts for the infraocular bone defect. So we can talk a little bit about it, like periosteum yes, periosteum no, and things like this. Yeah. So today I'm going to focus on MIVAN technique and on the buccal sliding palatal pedicle. You announced it very, very kindly. I'm grateful, like innovations, but it is more like modifications. It is, I put together some techniques, and actually I've done it long before these techniques were published. But then when I was about to write an article and I've done a proper literature research, I have found, oh, I can find a lot of these parts. So I gave always credit to the primary authors. So the Pedicle connective tissue grafts, they do have own blood supply, and this is what makes them irresistible, because they survive also on a badly vascularized basis. So I'm going to talk first about the MIVAN technique. MIVAN technique can be utilized for socket type 2 and 3 and for the ridges with horizontal axis. So I don't want to give a very, very long online lecture because I know people cannot follow it. We don't have so much attention. So I'm going to focus on MIVAN technique for type 2 and 3 sockets. MIVAN technique is basically simultaneous augmentation of hard and soft tissue. When we face a socket type 2, it means there is not a buccal bone, or socket type 3. Not only that the buccal bone is missing, but also there is a soft tissue defect on the buccale. Then we do have some alternatives. And I started many, many years ago with MIVAN technique, so I keep this is my first choice technique. Why MIVAN? In many cases, I don't feel very confident placing implants immediately in the sites with missing buccal bone. It is also more often, it's not only the buccal bone, but also a huge periapical areas. And then we need to place a very long implant. We do have anatomical structures here. And the aesthetic area, I don't feel good placing implants immediately at the time of the tooth extraction. So we have to preserve, not only to preserve, but to reconstruct this ridge. If we place grafting material and do a primary closure, face disadvantages of the coronary flap advancement. The mucogingival junction is displaced, then the zone of the keratinized gingiva is diminished, is moved on the palatally where we don't need it, and often we do see the scars. The second is if we deal with patients that don't have a thick tissue, a soft tissue, and I've seen it so many times in my practice, and if there is not a connective tissue graft underneath the mucosa, very often this tissue looks bluish, shiny, the stippling is missing, there is not a nice texture. So for this reason, a pedicle connective tissue graft, few reasons. One of them, I can place this connective tissue graft to cover the grafting material and the socket opening. Because this connective tissue graft has a blood supply from the palatal, it's going to survive. I can avoid coronary flap displacement. So, and when I take a longer connective tissue graft, I insert it into the buccal tunnel. So at the same time, the buccal volume is augmented, and I do have a connective tissue underneath the gingiva that is going to give me a nice appearance and nice gingival stippling. I am involved with many others that really admire immediate dental-alveolar restoration, and what Dr. Da Rosa is doing and publishing and showing really amazing cases. And maybe, Omid, we can also talk better after the lecture about indications, contraindications, why, when, what. This technique works very nice, but is really great that patients get immediately the alveolar reconstruction. We have both the ridge is reconstructed and patient has a provisional. This is a clear advantage compared to the stage procedure MIVAN technique. Here, one patient, the buccal bone missing, the tuberosity harvested, the cortical bone plate placed, the gap is filled with tuberosity bone chips. Patient got immediately provisional crown, and she's of course happy. Not one moment she had anything, anything removable like Essex or Maryland bridge that disattach. I really like IDI technique. Also, this technique I modified. This is somehow, I have it in my genes. I have to modify everything. I prefer to put a corticocancellous bone block graft and then to also densify this graft. At the end, I have a nice structure on the buccal. It is like socket shield. So I feel very, very confident for the long-term results. And this is what I really, really like. What I'm looking now at, it is hidden marketing for the application that I done these implant surgical procedures for the socket type 1 and socket type 2 and 3 decision process. And also IDI technique is one of the presented technique. So let's go back to socket type 2. Look, Dennis Tarnoff, the same man who said one miracle in time, and who used to do ice-cone-shaped membrane and socket grafted with allograft, and to stage the procedure for the sockets with missing buccal bone. He published in 2015 immediately implant placement, where basically, instead of the cortical tuberosity bone, there is a membrane and gap is filled with slow resorbable grafting material. But one must say that in this, at least in this paper, only the cases in premolar area, not in really important aesthetic area, are shown. Or this lecture from our dental XP friend, I always struggle a little bit with his family name, but Konstantinos is his name. Also the same principle, immediate provisional gap filling with xenograft. And this is what I don't like. I don't like this contact implant to xenograft. We can discuss it afterward. And we do have early implant placement with GBR. Basically, the tooth is extracted and then we wait 6 to 8 weeks until the soft tissue is matured and the socket opening is closed. Then we come back, open the flap, place the implant and do GBR. Immediately in this case, what we can see, and somehow no one talks about it a lot, it is if it's a central incisor and when we left the socket not grafted, there is also frenulum displacement. Not only if there is a deep attachment of the frenulum, also if the frenulum is 2 to 3 millimeter away from the tip of the papilla, I see it often at the second stage. What is now? We place the implant, we do GBR, and then we have to do again the coronary flap. And this frenulum goes really very, very much coronally. And I have a few cases that are suboptimal because of the frenulum. Later on, you can remove it with laser and do whatever, but somehow it stays always. Okay, in this early placement with the GBR, what I already mentioned is that I miss a connective tissue underneath to give a nice gingiva appearance. Gingiva looks bluish even if I have a nice volume. So what I then do with the socket type 2, you know, when the patient come, and many of them are young, beautiful people that had some tooth trauma in the childhood. And you know, one apicoectomy, the second apicoectomy, and they come to me for the third or fourth apicoectomy. But then you have to say, no, it doesn't make any sense that we have to take the tooth out. And each time, you know, I think I'm going to do something different. I'm going to place the implant immediately. I'm going to do here DR. But then I see these patients and they know my results, and not only my results, all my residents and students are utilizing MIVAN technique, and now I see more and more of my dental XP friends. When I see them, then I go back and do technique that I really feel confident, and that I really get a very nice long-term stability. This is 2 papers. One is like proof of principle, and the second paper showing long-term results up to 11 years. And you know very well, when you publish 11 years, the cases are already 15 years old until you hold all your patients, especially the half of my patients are back in Germany. So, and until the paper is written and reviewed, and everything is done, it's about 15 years, and the cases look really nice and stable. So I already mentioned, when I was about to write this paper, then I've done especially literature research, and I have found out that Fagan published already in 2008 MIVAN technique. MIVAN, it is nice abbreviation, very, very complicated term that I have to learn by heart before every lecture, interpositional vascularized augmentation neogenesis. But abbreviation is nice. And this is basically simultaneous augmentation of hard and soft tissues, published in 2008. I told you my first cases are done in 2004. So what is the modification was MIVAN done and published? He basically utilizes a pedicle connective tissue graft to cover the socket opening in order to avoid a coronary flap repositioning. So I do a buccal tunnel, and this is good for two reasons. One reason, I have more soft tissue volume, gingiva has a better appearance, and I have additional supply for this pedicle connective tissue graft. And we are going to see more to this when I come to the complications, and I will come to the complications. So, in MIVAN's work regarding hard tissue augmentation, he places in the most of the cases allograft. We don't have in Croatia access to allograft like in many other European countries, or even bone blocks, PRF, whatever. So I am restricted to use synthetic bone, autogenous bone, xenografts. So I combined it. I combined it utilizing a Tarnoff's ice cone technique, membrane that is shaped in ice cone shape. So the part of the membrane is placed to cover the bone, the histioenzyme, and the other part of the membrane is placed on the top of the graft. And the graft is composed in the layers. There is a layer of the xenograft. This layer on the xenograft is placed on the buccale, only on the buccale. And the socket itself is filled with autogenous bone. When I come back to this socket to place the implant, I'm going to place the implant in the vital autogenous bone. And the layer of xenograft is going to preserve the buccal contours. Sandwich technique by Mish, actually. I told you everything put together, what I knew or what I felt. So here, patient, the ice cone shaped membrane layer of xenograft, and the socket is filled with autogenous bone. And on the first CBCT image, you can see these are different cases. They don't belong to one case. You can see how it looks like it was before the definitive prosthodontic was delivered for the patient. On the second CBCT image, you can see this is the patient. I have done a socket shield for the other central incisor. So I had opportunity to get CBCT. It was 5 years after MIVAN technique. And this rich contour stays nice and stable. So here animation. So this technique, buccal tunnel is prepared, and then I prepare a connective tissue graft. When it's prepared, I put it back in this palatal pocket and take care about the hard tissue augmentation. And then this pedicle connective tissue graft is flipped over, not rotated. It's flipped over to this buccal tunnel. It is prepared with micro blades and tunnel knives. We do have this buccal tunnel. This video didn't play, but it doesn't matter. So let's see some cases. Very typical case, a young patient. And here what you can see, interesting detail, bone harvesting utilizing bone scrapers. It gives a nice quality of the bone in order to avoid a second harvesting place. Usually harvest the bone chips from the palate after I elevated the connective tissue graft, palatal, the cortical, very, very nice. And again, icon-shaped membrane, layer of xenograft, socket itself is filled with autogenous. This is immediately after the surgery. The patients usually get Maryland bridge and Essex, very often both of them. Maryland bridge, and then, you know, if it gets detached on a Saturday evening, they have Essex to put it. They don't need to go to that. And this patient, this case is done 5 years ago. She comes really regularly. Or look in this case, really scallop gingiva, and you really don't feel like elevating these papillas, like elevating this marginal gingiva. And I really didn't feel like placing immediately an implant, especially because it was a confluing cyst from the center and lateral incisor. We decided to redo endodontic treatment for the lateral incisor and to do MIVAN technique for the central incisor. And in the cases like this, I, you know, because I'm really, before I'm really sure the defect from the lateral incisor is going to be quiet, I don't want to place implant here. So we waited 4 months. 4 months is the time to be waited. This is how it looks like immediately after the surgery. Incision that you see, patch incision or buccal aesthetic flap, it was to degranulate the periapical inflammatory tissue and to do apicoectomy on the central incisor. But marginal gingiva is not elevated. This is how it looked like then before implant placement, and then after the prosthodontics delivery. I've seen the patient maybe 1 month ago. We already have 7 years follow-up for this patient. Everything's nice and stable, and papillas are here, and everything is here. So I told the MIVAN technique is for socket 2, also for socket type 3. This patient, it's an interesting story. When you look, when he came to me, he came on the January the 4th, and he had fight on New Year Eve or the girl, you know, and it took him 4 days to come into my office. And I like the story. This young patient, he had a multiple fracture of the central incisor, and because of this coronal fragment mobility, the gingiva and the papilla on the lateral incisor, they necrotized. It was the first day after the New Year celebration that we opened our office, and the waiting room was overcrowded. So I've done MIVAN technique here. One of my first cases, I was really in rush, so I was able to put only two sutures on the patella just to finish this surgery. And this is how it looks like, the healing. And afterward, he had the car accident, and again, fracture of the crown, but not of the implant. Or this case with long-term follow-up, 11 years, my office partner sent this image to me, and this is my favorite condition. I do have meanwhile a few cases, maybe a time to publish, but it's a hard work, this publishing job. Okay, this patient, look at this central incisor, and very simple treatment. Socket shield for the right central incisor and pedicle connective tissue graft. Socket was filled. It was not implant placed. In these cases, I can fill it with xenograft or whatever, or I don't need to fill it. And this is what the patient looks like. Only one surgery, nothing more. nothing more. Now, I almost regretted that I haven't planned to place the implant here. And this is how the patient looks like. So, of course, I see complications with the MIVAN technique. I must say that in all these years, and there is no one day in my office that I don't harvest connective tissue grafts. I am always, it's for whatever. And I never had the serious bleeding from the palatal, major palatal artery. Yes, I did have arterial bleeding, but I never harvested my grafts so nearby to the Auschwitz place. Now Germany is coming to the place, to the foramen where the great palatine arteria is coming out. So it wasn't difficult to stop the bleeding, and I think it's also a good topic to be discussed afterward. So now, what I've seen and what I have learned almost hard way. It is long story. I won't tell the whole story about the patient, why it was a hard way. I've learned that it takes at least 3 weeks before maturation, after the pedicle connective tissue graft, before we shape the site or support the papillas with the pontic that is coming into this connective tissue. It needs space because it's going to swell and it needs space. So if the pontic is so long, it is strangulation, but here you can clearly see advantage of the buccal tunnel, because the buccal part of the connective tissue has survived and the palatal part has survived independently from each other. Also on the case in the second row, this patient, she was heavy smokers. I have a lot of smokers among my patients. This patient is heavy smokers, and mostly I do see a superficial, like a sloughing and partial necrosis. Seldom. This is one case where I have seen almost the complete graft necrosis. This is the patient. He was, of course, it's always the patient's fault. It's never our fault. Here I've done live surgery for the students from the university, and everything went smoothly and nice. But afterward, the patient, he went into this biopharmacy, and he has bought all oils and creams and everything that one can buy in biopharmacy. And he had put everything one after the other onto this connective graft. One thing he didn't dare to do any hygiene. He was afraid to touch the adjacent teeth with the cotton, but he put everything. I think it may be also the reason. Maybe he's also a smoker, but there is a necrosis of this pedicle connective tissue graft, but again, the buccal part of the graft survived. So it wasn't difficult to manage this case. You see the initial situation on the left. It was a tooth with recession. He had a lot of surgeries before, a lot of xenograft here for no reason. And this is how it looks after 5 years. This pedicle connective tissue graft, the buccal part has survived. This buccal part, it was where initially there was a recession and the soft tissue was missing. So it was about the MIVAN technique. So let's see another topic, the buccal sliding palatal pedicle flap. So on purpose, I'm showing first the modified roll flap technique, because this is how this buccal sliding palatal pedicle flap started. I do a lot of modified roll flap technique the second stage surgery, at the implant uncovering procedure, or when I have a nice ridge, I don't need any veneer grafting, hard tissue veneer grafting. I start not with incision to the bone, but splitting the palatal tissue so I can do a modified roll flap technique. It's published by Sharp and Tarnov. It is basically the palatal tissue is splitted, and this connective tissue with periosteum is rolled underneath the buccal soft tissue. And of course, we can modify everything. Like in this case, I want to improve the buccal soft tissue for both of the implants, and at the same time, I don't want to let this bone exposed for the patient. So the part of this connective tissue I left exposed for the patient to have a better comfort. So, and this is how it looks like after the healing. It's really amazing technique. It makes very, very nice vestibulum and very nice soft tissue thickness. In this case, this is the first case how I came to the buccal sliding palatal flap by chance. I planned to place the implants utilizing denser burrs to expand the reach. I had the CBCT of the patient. I thought I'm still going to have 2 millimeters of the bone on the buccally, but I didn't have 2 millimeters of the bone on the buccally. And I looked at this connective tissue. I had to do CBR and what to do with this connective tissue. First idea is to cut it and to put it like a free connective tissue graft. But then what for? We can still do it at the implant uncovering procedure. And then I thought, wow, why don't let it exposed? It has a pedicle, it has a blood supply from the buccal flap, and I'm not going to flatten my vestibulum. And this is this disadvantage from the coronary flap advancement, that the patients, they go through the huge first surgery, and then we have a second and third surgery for the implant uncoverage, for the vestibulum reconstruction and gingiva strip and restriction, shrinkage of the tissue or the color of tissue. The patients, I mean, of course, we do it, and I still do it. But if we can avoid it, if we can minimize the amount of the coronary flap advancement, why don't do it? So this is a few graphics showing the buccal sliding palatal flap. The first incision goes about 1.5 millimeter, slide palatally to the crest of the ridge. I have forgotten to say that already during anesthesia, one has to check out the soft tissue thickness. And we need more than 2.5 millimeter, better 3 millimeter soft tissue thickness on the palatal in order to be able to perform the buccal soft tissue, buccal sliding palatal flap. So then we split the tissue. Of course, it goes into steps. The blade is angulated step by step. We dissect this tissue utilizing vertical incisions on the palatally underneath the superficial palatal mucosa flap. And then we finally elevate this connective tissue utilizing back action or periosteum. There are also very nice angulated periosteum. I love to combine this technique with guided soft tissue augmentation. It means that the implants are left to heal submerged, but they do have a healing abutment. What can we achieve with the buccal sliding palatal flap? We can achieve minor to moderate moderate flap advancement. I never try to let it expose more than 4-5 millimeter of this connective tissue. If I have done a huge augmentation and I need more soft tissue to cover the graft, then I combine the buccal sliding palatal flap with the coronally advanced buccal flap. But it is less advancement, absolutely less than usually. So when I posted the paper that was published recently, you already mentioned, then some colleagues put into the comments like, oh yes, we know this flap, it is from Tinti. Tinti, he published the palatal sliding flap. And in this place, I also want to say, and this is what I claimed already on the beginning, this buccal sliding palatal flap, it's nothing new. It is a new utilization of the old flap design. And it is completely different to the palatal sliding flap. Palatal sliding flap, it means that our first incision goes to the bone, and then we elevate the palatal tissue, and then we have to split palatal tissue coming from the apicale. It means that we don't control the splitting looking from the outside. We have learned, when we split the tissue, don't take your forceps and don't look inside, look from the outside. Have your assistant to suction from the outside. You just have to see the appearance of the blade in the tissue. Don't look at the blade tip. And here again, this is the palatal sliding flap. The palatal tissue is elevated, and then coming from the apicale, we have to split it and to open it. It is difficult to angulate the blade to be parallel to the superficial layer of the palatal tissue. So there is really a perforation risk. I've done a lot of these flaps. Actually, each time when I've done a GBR and noticed the palatal soft tissue has such a great thickness, then I used to do a palatal splitting, palatal sliding flap. But this is really, really technically demanding because of the perforation risk. And with this flap, we can also achieve a minor to moderate flap advancement. Here in this case, I combined the palatal sliding flap with guided soft tissue augmentation. As I already described, it means submerged implant healing, but implants have healing abutments acting like tenting screws. This is introduced by Salama and Garber by the literature, and utilize this technique very often. We can leave 4-5 millimeter of this connective tissue exposed, and for this amount, the amount of the connective tissue that we leave exposed, the amount of the coronary flap advancement is reduced. Like in this case, huge augmentation. Look at the initial rich thickness, and here it's not only the buccal sliding palatal flap. I have performed also a coronal flap advancement of the buccal flap, but so little that I didn't have to do any apically flap repositioning or any other art of the vestibuloplasty. And this is what we get then after the tissue maturation. Very, very nice soft tissue thickness. And when I started to perform the buccal sliding palatal flap, you know, until something you get into your habit, I found myself cutting all the way to the ridge, and I couldn't do then the palatal sliding flap. But now, when I know advantages of this flap design, I hardly touch maxilla without splitting the palatal tissue immediately. So we can utilize it for bond closure after ridge augmentation and implant placement, like in this case. When we come for the second stage surgery, it's really great for these sides to do then again the roll flap, because as the literature says, some 9 weeks after the first harvesting of connective tissue graft, we get a better soft tissue quality and quality. This is the patient after the prosthodontic treatment was finished. We can also utilize the palatal sliding flap for the bond closure. And this is my favorite combination, and this is why Maurice Salama and me published together this paper in combination with guided soft tissue augmentation, like in this case. Look here. Of course, today I got the question if we can, what is the difference or what is the advantage to the apical flap repositioning. The difference, there are a few differences, but what I see the biggest advantage of the apical flap repositioning is for the full arch cases. This is nothing that I want to do in aesthetic area. And here was really a good utilization of the buccal sliding palatal flap. The implants are placed, guided soft tissue augmentation, veneer grafting, and instead of the buccal flap repositioning, the buccal sliding palatal flap, and this is how the tissue looks like after the maturation. The final result is not optimal, but this is the long story about this patient. Look on the right, we started with 3 units and we have done 2 units out of it. It wasn't easy, and this is lateral incisor. Another case showing utilization here, implant placement with the and simple the buccal sliding palatal flap. This is the tissue thickness that we get when we combine the palatal, the buccal sliding flap with guided soft tissue augmentation. Or here, again, initial situation, the buccal bone is insufficient. Here, my favorite grafting material, dentin graft. The socket is filled with the dentin graft. Now the ridge was still rather thin. Also, densification was utilized to expand this ridge. GBI is done here, PRF measures, and again, instead of the coronary flap repositioning of the buccal flap, the buccal sliding palatal flap. And this is really, I would say, a minimally invasive surgery with nice results. And we can utilize it also after the soft tissue augmentation. In this case, it is a dentulous patient and implant second stage surgery, and I wanted to improve in the aesthetic area to have a nice emergencies profiles for the teeth. Connective tissue graft, pre-connective tissue graft was utilized to augment the tissue, and the buccal, again, buccal sliding palatal flap in order not to displace the flap coronally. Or here, initial situation, just 2 layers of collagen matrix and the buccal sliding palatal flap 4-5 millimeter left exposed, and it was very efficient also in this case. It survives very nice. Do I see complications? Of course I do see complications, like with all other techniques, but I will show you the most often, the most frequently complications, like in this case. Again, the healing abutments were placed, everything went very smoothly, but this is how the patient presented after 1 week or 5 days, I don't remember exactly. One of the healing abutments was partially exposed. Why did the place where it happens is very logically. It is the margin of the flap, it is on the palatal, and this is what I've seen in few cases. Meanwhile, I've done a lot of cases with guided soft tissue augmentation and buccal sliding flap. And this is what I see, that the flap opens palatally on the healing abutment. So why it happened in this case? The patient it was planned for her to have a provisional bridge after the surgery. But because of her very, very busy agenda, she couldn't come earlier to get the teeth prepared for the fixed provisional bridge. So she placed A6 that and it was also broken. I placed this part of A6, it doesn't sit completely now. I didn't want to put it all the way down. And you can see clearly impression of the pontics, this A6. It is like for all other sides after the grafting, especially if we have a hard healing abutments underneath the flap, so much better if we have a fixed provisional bridge to protect the site. But look, this is the patient after the tissue maturation with provisionals and the soft tissue height measurement. And this is then afterward the same procedure. I mean, the buccal sliding flap on the both side, one side very periodontally advanced periodontitis, the other side initially thin ridge. This is the complication that I see, that the healing abutments, if the patient don't have a fixed provisional bridge and teeth supported or implant supported, and they come after 6 months or 8 months or something like this, then the palatal part of the healing abutment gets exposed, but it doesn't really any hard consequences because on the buccally we still do have a nice soft tissue thickness. So now I click on the stop share and come back to you.
Can you hear me now?
Yes, I can
Yeah.
hear you now.
Thank you. Thank you so much, my friend. It was amazing as always. And truly, as I said at the beginning of your presentation, uh, the modifications that you made really help us better obtain better outcome as you presented. And it truly means a lot because I was doing the modified roll flap technique, for many years for grafting and augmenting the buccal contour in especially posterior cases, which sometimes we have lack of enough good tissue, but really never thought about it that, modifying the modified roll flap technique, exactly the thing, buccal sliding flap that you showed, to use that connective tissue instead of rolling it inside, using it and minimizing the amount of coronary advancement of the flap. And that's very genius because, it helps truly minimizing the need for the second surgery for the patient. And it's truly something. So, and as you put in your last slide, for all the audience interested, the article is out in IJPRD, the October 2020 version of it, edition. So really look at that article for get more details about this technique by dear Snjezana Pohl. My friend, before we start the discussion, I would like to show you the book, and you, especially on the first page of the contributors. So I truly should give you in person when I see you. So I just wanted to share with you now before we go to the discussion. So as you said, because the source in both of these techniques is from the palate. So I want to know, because you talked about limitations a little bit, but I want to know, especially in the cases that the patient have deep palatal vault. I mean, their palate is very deep and it's not flat. And usually in those cases, the thickness of the connective tissue is not that much. Is it one of your criteria to measure the thickness of the palatal tissue before choosing this technique, or you don't find any limitations by going with this technique in your patients?
You are right. One have to measure the palatal soft tissue thickness. We don't ultrasound, we don't even need a periodontal probe. It is simple when we are doing injection, we just probe with our needle, and then if I have sufficient thickness, then I go for the buccal sliding palatal flap. If it's not sufficient, then I don't perform technique. It has limitations, absolutely.
Yeah.
It's not very often that anatomy doesn't allow for it, but it, yes.
Yeah, and regarding using these kind of techniques, especially you showed some cases like single lateral or central incisors. I want to know if you want to say that reflecting or raising the papilla or not. With this technique, do you raise the papilla or you go from the aspect of the socket and keep the papilla attached during the surgery?
I go from the aspect of the socket.
Mm-hmm.
I don't raise papilla. I avoid raising papilla whenever possible, especially in the aesthetic, of course, in the aesthetic area, especially in the area central-lateral. Avoiding just tunneling, just I can also do a detach a periosteum from the buccal if I need some coronary flap advancement, but don't cutting the papilla, never.
Great. And Snjezana, about the buccal sliding flap technique that you showed, the second part of the presentation. What should be the length of the end of that pedicle to go underneath the palatal flap to make sure the vascular supply of it is enough? Because when we bring it out and when we graft the buccal aspect and suture it back, should we have any criteria that how many millimeters we should have at least underneath the palatal section to make sure that the vascular supply is enough or not?
The majority of the vascular supply come from the buccal flap, and only a minor part comes from the overlying palatal tissue when we stuck the flap underneath the palatal tissue. So 1 millimeter, 2 millimeter, 1 millimeter, in my experience, it's enough. It is important to not have any mobility, to suture the flap, to have everything fixed, but 1 millimeter underneath the palatal flap is enough.
Great. Great.
Mm-hmm.
That was a great point.
And this is also,
Yeah, go ahead.
First, I wanted to come back to your first question, and I will come back to the second question. Sure. The first question, we talked a little bit about papilla, and what is also good with this technique, when we split and we don't go all the way to the bone and we never elevate the dentogingival complex, we detach from the adjacent tooth. When we split, then also this big part of dento-gingival complex stays, and this is very, very important to prevent bone resorptions and then papilla atrophy. So the second that we talked was about how much should we place the flap underneath the palatal tissue, and you agreed with me 1 millimeter is enough, and this is what I see in my cases. What is important, what happened to me initially more often was that I underestimated this flap. It means that I mobilized the coronal flap too much, and I had dissected 5-6 millimeter of the palatal connective tissue. When I sutured, it disappeared underneath the palatal tissue. So maybe only 2 or 3 millimeter were left exposed. And this is a pity. So we don't need to mobilize so much the coronal tissue. If we already had, then we have to play with the sutures and to take care to tighten too much and to really utilize the whole potential of this flap.
Yeah.
This is for one, you know, if you start, if you want to see how this works, and so this is what happened to me few times. You know, you are splitting, very nice, and pictures were great, and then you look, oh, I left only 2 or 3 millimeter exposed, and I could have done much more.
That was a great point. And, you know, regarding modified event technique that you presented, for example, you showed the ice cream, you know, it was a combination like ice cream cone, place an implant, put the membrane there, put a graft there, providing a tunnel there, and then put the kind of tissue pedicle underneath that.
Yeah.
Definitely, it's. I believe that this technique works, but just as a question that came to my mind, maybe for some of our audience, is the same question. When we are placing an implant into the type 2 socket, so we don't have any buccal plate and we don't have any vascularity from the titanium surface, and we put a graft material on top of it, we put a membrane on top of it, and we put a connective tissue on top of it, and we have the flap, the tunnel. So I want to know, did you face any failure in this technique caused by lack of enough vascular supply? I know it's a pedicle and it comes from the palatal, but maybe because we are doing so much graft in the area, have you experienced any like exposure or any necrotic tissue during the healing phase that forced you to trim it and do some modifications again, or no?
Honestly, not. And not because I stage. I do ice-cone-shaped membrane and sandwich bone augmentation covered with pedicle connective tissue graft. And I wait 4 months before I place implant. And then I place implant mostly flapless, and this is what I feel comfortable in the cases with missing buccal bone in a static area by staging the procedure. I admire IDI technique. I've done it in not many cases, but few cases. But you know, when the patient comes to me, these beautiful young patients with a gummy smile, and they expect magic, they expect natural looking teeth, not implants teeth with nice gingiva, then I don't dare to place implant immediately, very long implants, and to go, no, I first do a socket reconstruction, then I come back and place an implant.
That was a great point. And Snjezana, about the membrane choice in modified event technique, how rigid your membrane is. You know, if you go, for example, with like the one by, I forgot the name. We have the one by Zimmer, I think, which is a very rigid collagen membrane. Or do you have any other choice to make sure that collagen goes uh, smoothly in the place and don't get completely hydrophile and to be easy to handle? I mean,
I use the, mhm. I use simple the non-cross-link collagen membrane,
firstly. Mhm.
BioGuide membrane. I for 20 years, for I don't know how many years. One should take care. First, I, 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 uh, I cut the proper shape, just taking a paper from the sutures. So I make sure that they have a nice shape, and then I cut my membrane properly. So I'm able to put it just in one move before it gets wet. So I have it safely in the place. uh, then I put a layer of xenograft, fill everything with autogenous bone. Meanwhile, the membrane is wet and it goes very nicely, covering the grafting material and the socket orificium. I, I don't like rigid membranes, the handling with rigid membranes.
Yeah, that was a great point because, for example, so many people think, like myself even, that maybe cross-link membranes are easier to use in such techniques. So because you're very truly expert in this field, I wanted to know your idea about it, and that's interesting that you're a great fan of non-cross-link, and it works perfectly. Um, Also, regarding the final case or two cases that you showed, that you faced the exposure of the healing abutment after the sliding flaps that you utilized. In the cases that exposure happens, do you prefer or ask the patients just to clean, or you prefer to uh, remove that healing abutment and connect a longer one to make sure that the soft tissue comes around it?
I've done each time just keep cleaning these abutments and never seen any complication
So
because of
you
it.
don't
I
change
have
healing abutment.
meanwhile, it's
Yeah.
it's really very safe.
Yeah,
Mhm.
great. And one more question regarding your palatally sliding flap. I want to know if you have enough thickness in the palate. Do you prefer to go full thickness to remove that graft connective tissue from the palate, or you go with the partial thickness? I mean, like you said, you keep the periosteum there, or you try to just roll them out, outside there.
It depends on the soft tissue thickness, if it's really, really thick, you can also do a luxus and left periosteum for the nice healing, but mostly you don't have such a thick palatal tissue. So I take periosteum together with connective tissue, and then take care that the superficial layer has sufficient thickness. But it's also nice to place a PRF membrane if I have. Normally, I do have. Normally, these are the cases with some veneer grafting, and all of us have some PRF membranes just for the safety underneath this palatal dissected tissue. I
Yeah.
usually place some PRF membrane, but not always.
Thank you so much, my friend. I again want to thank you for your valuable time that you shared with us, and I'm so grateful again for that. And just hats off, my friend. Thumbs up.
I enjoyed it very much. Looking forward to meet you finally in person.
Thank you so
Keep doing, Omid.
Thank you so much, my friend Jazana. I have to say again, I can say it many times, it was my pleasure to host you. And we all truly admire your work, your passion, and follow your publications, follow your beautiful surgeries. and what you bring to all of us. And really, Queen, Diva, all of them suits you. And thank you so much. Looking forward to see you soon. Stay safe and God bless you, my friend.
Stay safe. Thank you so much.
Thank you.
Bye.
Bye-bye.